Good afternoon, everybody. We're here for our Wednesday webinar. Today we have Dr. Nilay Gandhi, who recently graduated, well, not that recently, but 8 months ago, completed his residency fellowship at Johns Hopkins University. He's a urologist who's here in our community working with Potomac Urology. He has a couple offices, and he's very active in our community. And is supporting the Zero Prostate Cancer Run/Walk, which is coming up on Father's Day. He emphasizes patient education. He's got research interest in prostate cancer, bladder cancer, erectile dysfunction, and neoadjuvant chemotherapy. So I think that we've got a great speaker here today, and I look forward to hearing his talk, which is covers a variety of issues, but more importantly, or at least one of the foci, is going to be an update on the recent controversy involving PSA screening. So let's enjoy this conversation with us.
All right. Well, thank you very much for that introduction, Dr. Vitek. So as he mentioned, I'm Nilay Gandhi. I joined Potomac Urology in September of last year, and I want to talk a little bit about PSA screening for prostate cancer and an update on the recent controversy to discuss where we go from here. And just like the picture here on the bottom right, we have the physician, and the question now becomes, do we test for PSA or not, given the latest recommendation? So, you always wonder who's the person that's talking to you. I just put this slide up. Just like you mentioned, I'm Dr. Gandhi. I graduated from Johns Hopkins Urology, the Brady Urologic Institute in Baltimore, Maryland. And they've perennially been ranked within the #1 for 21 consecutive years, but also in the top 5 urology programs for as long as I can remember. So a lot of pioneers that came through here that have been able to cultivate and teach the residents coming through to learn how to analyze and also how to interpret the information with research to really divide this up into categories to discuss with primary care physicians as well as with patients. So starting off, this happens to be June is National Men's Health Month. So this is a perfect time for this discussion. And a lot of what I try to do in the community and with patients is increase awareness. I think by increasing awareness and increasing patient education, through that we can actually make significant changes. And so with June being National Men's Health Month, we are actually working together with Zero Prostate Cancer to sponsor a prostate cancer 5K run and walk. This will occur on Father's Day, June 19th, in Pentagon City. So if anyone is interested, please definitely check out our website. There's a link that's listed here as well, that if you'd like to just see what it's about, contribute through donations, or just inform your patients that there is an outlet for them to be able to bond with other prostate survivors and participate in a charitable event that helps to raise awareness about prostate cancer. To date, we've raised over $12,000 over the last month or so to really help support the community in terms of prostate cancer awareness, but also prostate cancer support groups for all of the men diagnosed. To go with that, as June is Men's Health Month, September is National Prostate Cancer Awareness Month. A lot of my focus is how there are a lot of women's health centers within the area nationally, and everyone knows that October is Breast Cancer Awareness Month and people wear pink, and we're really trying to increase the focus towards men's health and conditions. And so September is National Prostate Cancer Awareness Month, which people wear blue, but in addition to that, we actually grow beards. There's a campaign called Septembeard, and here's just a few pictures of our office with some of the doctors as well as the girls in our staff, where we were growing our beards out throughout the month. But it's another way to raise awareness. Patients ask you all the time about it because it's something different. And through this year, we were able to raise over $1,000, which actually it ranked 5th in our Eastern Division and 24th nationally. So this was a small cause, but we're hoping to make this even bigger this year. And again, it's all about raising awareness. With raising awareness, again, comes Movember, or you may know it as No Shave November. But again, it's to raise awareness towards men's health during the month of November. And we actually partnered this year with the Potomac Nationals to be their official sponsors for Movember to, again, help raise awareness throughout the community. And there's all sorts of different mustaches that you can choose from. Whichever one is your style, they're all appropriate. And these are just a few pictures of our group, again, sporting mustaches, where we also had our girls having these fake, colorful mustaches that, again, as they would bring patients back or take care of the patients would ask them what's that for. Just easier ways to help raise awareness. So as we go about that, we're wondering, well, why are we raising awareness? What are we trying to achieve here? And that's where this focus of the talk is heading. And so I just wanted to start with just a basic, what is the prostate? And as you can see, it's located below the bladder, and it's typically the size of a walnut. It's about 30 cc's or 30 grams is the average size of a prostate. And so when we actually measure the size of the prostate, that's how we can tell if it's enlarged. And typically, a 30-gram prostate will correlate with a PSA of about 1.5. So those are two ways to kind of know the size of prostate when you're examining the patient. And its involvement is that it surrounds the urethra. And so that's what explains that when the prostate enlarges over time, that's where you can experience urinary symptoms. Additionally, the ejaculate fluid it's connected through the prostate. The ejaculatory ducts run through the prostate, and so that's where you also have involvement with sexual function for the prostate role. So we're talking about raising awareness and talking about PSA, and the reason for all of this is that prostate cancer is the most common cancer in American men. Over 220,000 men were diagnosed last year alone. But the important fact is, if you look at this graph over on the right side, there's almost a 99% 5-year survival. So what that tells us is that, yes, we are diagnosing a lot of prostate cancer, and it's the most common cancer in men. However, it's highly curable, especially when detected early, and that's a very important point. For the American male, the lifetime risk of developing prostate cancer is 1 in 6. That's a very real risk. That's if you are sitting in a cafeteria at a table, 1 man out of every 6 will have, that's almost 1 in every table, will develop prostate cancer. And if you look at the timeline, back in the late 70s, early 80s, that risk was 1 in 10. But as we've been monitoring it now, we're at about 1 in 6. And it's the second leading cause of death in American men. So that makes it a very important topic that we definitely need to be aware of and properly take care of. The purpose of this slide is to show that it can happen to you. Like I said, it's 1 in 6 risk. And so a lot of people feel, well, I won't win the lottery, or this couldn't happen to me. But you see that there's a lot of famous faces here, and even the invincible James Bond, Roger Moore, he's up there, and he developed prostate cancer. So a lot of these men, they've undergone various treatments, and they've been cured of their prostate cancer, and they use their publicity to help raise awareness. So what are risk factors for prostate cancer? As you all know, age is one of the most significant risk factors toward prostate cancer. And if you look at this graphic, the older you get, the higher your chance of developing prostate cancer. And we've got about a couple peaks, mainly right here in the age categories of 55 to 74 is where we have the majority, almost 70% of our prostate cancer diagnoses. The median age at diagnosis is 66. So again, 55 to 74 is our highest yield target group for prostate cancer. And when we talk about death, there's a lead time of almost 14 years. So that explains why people say a lot of times you die with prostate cancer rather than from prostate cancer. And a lot of that is low-risk prostate cancer. So the median age of death is 80, and as you can see, according to this graphic, the majority is after the age of 75. So for diagnosis, we're talking about age 55 to 69 is the highest yield, and for death is typically after the age of 75. Second most common in terms of risk factors would be race. As you all are aware, African Americans tend to have a higher incidence of prostate cancer than white or Hispanic American men. In addition to that, African American males tend to have more aggressive prostate cancer, and their cancer tends to be hidden within the prostate that's not easily biopsied. So if I had two gentlemen who were age 60 standing here next to me, they both had the same comorbidities, they both had a PSA of 4.5, and they both had prostate cancer, just from those factors alone, the African American gentleman would have a more aggressive prostate cancer, and it would have been more difficult to detect than his Caucasian counterpart. This graphic demonstrates exactly what we were just saying, where you have a higher incidence in African American men than any other race, almost twofold. And when you look at prostate cancer death, you see the same pattern. You see that you still have a higher incidence of death within African American race. A lot of this can be related to genetic factors, and there's been so much research going into this to say, well, if race plays a role, is it genetics, or is it dietary, is it environmental, is it socioeconomic? And there's been a lot of research into the genetics because the risk of prostate cancer is increased almost twofold in men who have first-degree relatives, whether it's your brother or your father. So genetics definitely plays a role, and these are just a sampling of some articles that have come out in the last few years. Again, just focusing on genomic profiling and trying to truly identify causes of prostate cancer. And I think this will soon be the future of targeted gene therapy for prostate cancer, but also for diagnosis. There's a lot of research that's gone into this, given the Human Genome Project. So to the main topic at hand today, talking about prostate cancer screening. When we talk about screening, you know, there's two main tools that we talk about, and that's the digital rectal exam and that's the PSA blood test. Prior to 2012, I think it was almost standardized across the board that when a man reached the age of 50, he would obtain a digital rectal exam and a PSA blood test from his primary care physician as part of routine prostate cancer screening. And there would even be, you know, free prostate cancer screenings held almost every weekend at different health fairs. And if a man was, you know, had risk factors or was African American, there was consideration that the screening would start at age 45 or even age 40. And I'm going to discuss what changed in 2012 to where the field is very muddy right now. There's no standardization in terms of who gets screened, who doesn't, and that's led to a lot of the confusion and controversy. So when we talk about digital rectal exam, you can detect abnormal prostate findings, including nodules or asymmetry within the prostate that may show signs of early or even late and aggressive prostate cancer. Almost 85% of cancers can be detected with finger examination, but those tend to be higher grade. And a digital rectal exam is not good in its own right, but its best use is in combination with PSA. And one of the examples I'll mention is if you press with your index finger on the tip of your nose, you can feel the cartilage, you can feel that it's soft, it's spongy, and that's typically what a normal prostate should feel like. But if you press on your chin, then you can feel it's a little firmer, it's hard, and that's what a very aggressive prostate cancer may feel like. And you can feel that on just one side or the entire gland. But in addition, you may feel a nodule as well. So these are different ways to try and find out if prostate cancer is occurring. Now, the importance of the digital rectal exam is that you could have a gentleman who has a normal PSA of 1.5, but he could still harbor highly aggressive prostate cancer, because the more aggressive the cancer becomes, the less likely it resembles prostate tissue, therefore it does not secrete PSA. So even though you have a normal PSA, by checking the digital rectal exam, you would be able to identify an abnormality that could potentially save that gentleman's life. When we talk about PSA, so that's prostatic specific antigen, it's a protein that's made by the prostate and released into the blood, and that allows us to detect in terms of if they're at an increased risk of prostate cancer. However, PSA can be elevated for numerous reasons. the most common being prostate cancer, and that's why we use it as a screening tool, but also in gentlemen with BPH, with prostate inflammation, or even a urinary tract infection. Men who get a catheter for urinary retention can also have an elevated PSA. Bikers, they tend to have an elevated PSA just due to the riding on a bicycle seat can affect their prostate. And also after sexual intercourse, your PSA can go up. So there are numerous factors for an elevated PSA, and that requires further investigation to see if it's a true result that requires intervention. When we talk about PSA, we talk about the number, and always the magic number everyone hears is a PSA of 4. And so typically the rate of positive predictive value for prostate cancer goes up as the PSA increases above 4, and as it gets above 10, the predictive value increases even higher. Additionally, there are age-specific reference ranges where if a gentleman is within the age of 40 to 49, you expect their PSA to be between 0 to 2.5. So if someone there comes in with a PSA of 3, that's actually abnormal for their age. So you can't always go by the 4.0 golden rule. There also is age-specific reference ranges. But that's also part of trying to improve the accuracy of PSA as a screening test. With that, when we have PSA, we look at trends. And when we look at the trends, we want to ensure that the velocity, the change of the PSA from year to year, is not going up at a rate higher than 0.75 per year. If the velocity is increasing at a higher rate than that, those patients are at increased risk for prostate cancer. We also look at free PSA, which is a ratio of the free to total PSA, and we found that those men that have a higher free percentage tend to be more in the BPH category versus the men who have a low free PSA, less than 10%, they tend to have an increased risk for prostate cancer. As there's been all this debate regarding the utility of PSA, there's been 3 new tests that have emerged in the field of diagnosis trying to assist with improving the accuracy of PSA. The Prostate Health Index is FDA approved, and it looks at different components of PSA and finds that if you have a high number, which is defined as greater than 55, you have a significantly increased risk of cancer and require some sort of intervention, starting with a prostate biopsy. If you have, there's a urine test called PCA3, and that also shows that if you have a high score, you're more likely to have cancer. And then there's a blood test called the 4K score, which determines that if you have a high chance of identifying a high-grade cancer on prostate biopsy. So there's these new tests that are out there. I put the costs as well because right now, majority are not covered by Medicare except the PCA3, and so some of this becomes out-of-pocket costs. Some become subsidized by the companies, but these are different conversations that we as urologists also have with the patients to try and make them better informed so we can truly target those who are most at risk. When we look at prostate cancer mortality, that is the purple line that you see right here. And as you can see, we slowly have had an increase in prostate cancer mortality. And we had an increase right here, a sharp jump, and a lot of that was due to the introduction of PSA screening. And the reason for that is that once PSA screening was used routinely, we were identifying more cancers, therefore more people were dying of prostate cancer. However, as that stabilized, you see that there's a decrease in the trend. So definitely an effect on prostate cancer mortality associated with PSA screening. So much of the problem was that, like I mentioned, you have overdiagnosis. That when you have patients and PSA screening for a general population, you're going to find a lot of prostate cancer that may be clinically insignificant. But once cancer is detected, then you have treatment, and a lot of these patients were having over-treatment. So we were starting to have a lot of problems with over-diagnosis and over-treatment, and that's what led to the difference and led to new recommendations. So in 2012, the United States Preventive Services Task Force looked at the evidence, and they came out with a grade D recommendation saying do not use PSA-based screening for prostate cancer. And this changed the game. And a year later, the American Urological Association, which is our governing body, they were like, wait, now PSA makes a difference, but I agree, we are having a problem with overdiagnosis and overtreatment. And they looked at data, and they actually recommended the greatest benefit of screening occurs in men aged 55 to 69. And if you recall, that's also the highest yield when we looked at the incidence of prostate cancer, tends to be within that cohort. So these recommendations were based off of two studies. One that was performed in the United States called the Prostate, Lung, Colorectal, and Ovarian Cancer Screening Trial, or PLCO. They looked at over 75,000 men and separated them into PSA screening or no screening. And after 13 years of follow-up, they found no change in prostate cancer mortality between the two groups. Just last month, there was a reanalysis of their data that's published in the New England Journal of Medicine, and it actually found that a significant amount of the men in the control, non-screened group actually received PSA screening. And they found that there was a survey that's conducted, and it's called the Health Status Questionnaire, that was administered to the men. And they were asked if they've ever received a PSA blood test, which is that first question saying yes or no. And if they received a test outside of the past year, so 2 or 3 years ago, they were counted as not being tested, even though they had been screened for prostate cancer. So a lot of the data was flawed, that the PLCO actually was comparing two groups that underwent screening. That's why they found no difference between the two. And that's where the control group actually got 90% screened, and the screening group was 80% screened. So that was the big reason why this study was flawed. The European study looked at similar cohorts and aged 50 to 74, and they actually found that there's a 21% lower mortality in the screening group. So they showed a benefit of 37 cancers are needed to be detected to prevent 1 prostate cancer death. And this was also published in the New England Journal of Medicine at the end of last year. And it demonstrates that with the initiation of widespread mammography, the incidence of metastatic breast cancer has not changed. However, with the initiation of widespread PSA screening, you have a significant decrease in metastatic prostate cancer, to demonstrate again the effect of PSA screening. So surprisingly, the Centers for Medicare and Medicaid Services actually stated that primary care physicians will be monetized to not screen patients for prostate cancer. And this was in November, and this was because the task force recommendation was grade D, which is not covered by Medicare and Medicaid services. And there were a lot of opinion editorials coming in the New York Times, the Washington Post, talking about why doctors should not be punished for giving prostate exams. But when we look at the impact of that task force decision, we see that over 75% of providers actually changed their practice patterns since those recommendations came out. What's shocking is this statement right here, that almost more than 50% of providers now do not routinely do a digital rectal exam. And this was not even specifically addressed in the task force recommendations. They only discussed PSA. And when we look at that, the rate of PSA testing has decreased by 50%, especially in the targeted group of ages 50 to 69. And that represents a problem that we're having now, where it's not standardized and people are unsure whether to screen or not. As of March, the Centers for Medicare and Medicaid Services actually dropped the proposal to penalize physicians for performing non-recommended screening tests. And what they came up with was they are going to work together with different agencies on forming a Transparency and Accountability Act that will include primary care physicians and urologists to the group to ensure proper assessment of the data so that we can come up with formal recommendations, which will hopefully come out at the end of this year or next year. So the basis for all of this table just demonstrates a lot of different organizations, a lot of data, but it all comes down to shared decision making, having these discussions with your patients so that you can come up with what is the best case scenario for each patient on an individualized basis. So what do we recommend as a group? So we say no screening prior to the age of 55 unless the patient demonstrates significant risk factors. If you have a patient who's 45 and he tells you his brother got prostate cancer at 47 and his father had prostate cancer at age 50, he is at high risk. If you have men between the ages of 55 and 69, those are the ones that need generalized screening. They're the ones that can get PSA screening every 1 to 2 years. And after the age of 70, we typically don't recommend PSA screening unless that patient has greater than a 10-year life expectancy. At that point, if they were to be diagnosed with prostate cancer, it would tend to be clinically insignificant and would not be a cause of their mortality. Again, shared decision-making for each and every patient. So, as I said, a lot of these problems were due to overdiagnosis and overtreatment, and we've tried to address those issues by having targeted screening to minimize how many men are diagnosed that have clinically insignificant prostate cancer, and overtreatment by instituting these policies called active surveillance, which I just want to briefly mention. These are various treatments for prostate cancer that we discuss with all of the patients diagnosed and come up with a plan that's most suitable for them. But with active surveillance, we actually monitor their prostate cancer if they tend to be low risk or very low risk, and we follow them with PSA and digital rectal exams every 3 to 6 months, and they get a biopsy every year to monitor for disease reclassification to see if there's any increased signs of aggressiveness. And using this, there's about a 99 to 100% disease-free survival at 5 to 10 years. So it's a very effective way to prevent overtreatment in patients. So again, to close, I just want to mention this is my group. This is Potomac Urology. We're 5 guys. We're not the burger joint. We're just a bunch of urologists who we like to have a good time and counsel patients and educate and be involved in the community. Definitely check out our website. You can get up-to-date information on new treatment options we offer regarding a variety of urologic conditions, whether it's oncologic, whether it's due to BPH, erectile dysfunction, kidney stones, female urology, infertility, a lot of different options. Also, we do a monthly electronic newsletter. It's called Nuts and Bolts. If you are interested, it comes out once a month, and it's topics pertinent to your practice. I sent out an edition last month discussing something similar to what we just talked about today, the PSA screening controversy, and our monthly edition for June will go out this coming Monday, and it will be regarding erectile dysfunction management. So if you're interested, my email is listed there on the slide. Definitely shoot me an email, and I'll add you to the list so that you can get a copy of this. This is what it shows up as. So we just discussed, a few options discussing different community events, but also the topic at hand. To show the benefits of research, this and community awareness, over 23 years, they came out with 6 new medications for metastatic prostate cancer. But due to the increase in awareness and research dollars, in the last 3 years, we've had 5 new drugs. So that shows the power of community awareness and research donations. So again, I bring up that on Sunday, a week from this Sunday on Father's Day, we are doing a prostate cancer run and walk to increase the awareness and help support the community. So if you're interested, please definitely check out the website, come join our team, or let your patients know. But we look forward to working together. And that is all. I'll take any questions if there are any. Thank you.
Thanks, Dr. Gandhi. We'll check to see if we have any acute questions, and doesn't look like we do. So thank you for a great webinar, and hopefully we'll see you guys on Father's Day out for what I think will be a 5K walk. Some of you other guys can run. Have a great couple weeks, and we'll see you in 2 weeks. Thank you.